My name is Terry Mamounas. I'm the medical director of the Comprehensive Breast Program at Orlando Health Cancer Institute, and I'm a breast surgical oncologist by training. So the question is, how do you use frozen sections during breast surgery? And I must say that the use of frozen section in breast cancer continues to decrease over the years. Frozen section is rarely used, I think, at this point for intraoperative margin assessment during breast conserving surgery. And although in experienced pathology departments, occasionally intraoperative frozen section can lead to identification of tumor at the margins, and obviously the goal is to decrease reoperation rates, so this has been shown in few studies. Its widespread application has not gone on, since obviously it is cumbersome to do during surgery, and of course it prolongs the operative time. Another approach that people have used is touch prep cytology for the margins, and that's another method that we can utilize to assess margin status. But again, that's also a cumbersome method, and its utilization also continues to increase. This is essentially cytology at the margins. But even gross inspection after inking and serial section of the lumpectomy specimen by the pathologist, which used to be the most commonly used method for intraoperative assessment of lumpectomy margins, is now actually used considerably less frequently, given the recent uptake in the use of intraoperative specimen radiography for the assessment of the completion of resection during lumpectomy. That's something we do very often now. So this is a quick method for visualizing the breast lesion and the healthy tissue surrounding it, and we get the results within minutes in the operating room, and can be done by the surgeon. So images can be obtained. We do 2 orthogonal views, and that provides us with good information, the proximity of the lesion to the edge of the specimen, and these images then were forwarded to the radiology department for review. So again, we don't use much frozen section for the primary breast tumor anymore. Frozen section, though, is currently used mostly for the intraoperative assessment of sentinel lymph nodes. But even its use in this indication has also diminished in recent years. And that's because patients who have clinically negative axilla and currently undergo breast conserving surgery and sentinel lymph node biopsy, usually breast conserving surgery is followed by breast radiotherapy. Those patients don't typically require frozen section assessment of the sentinel lymph nodes, given that if the nodes are negative, which happens about 75 to 80% of the time, no further surgery in the axilla will be required based on results of multiple trials. And in the remaining 20 to 25% of the patients where 1 or 2 sentinel nodes are involved, based on the results of the ICOSOC trial and other trials, prospective randomized trials, there's showing no outcome differences whether you complete the axillary section or not. In these patients, typically no further surgery will be required as well. So there's no reason to do frozen section for those. And the same logic appears also applies to patients with micrometastasis in the sentinel lymph nodes, where axillary dissections routinely not perform anymore based on randomized trials showing no difference. So that also has decreased the use of frozen section for the lymph nodes in patients that present with surgery first. And for patients who present with clinically negative axilla and are found to have more extensive lymph node sentinel lymph node involvement at surgery, knowledge of that information intraoperatively doesn't necessarily lead us to make a decision to do an axillary dissection at that point, because we now have phase 3 data, for example, from the Ameros trial, where such patients, when they were randomized to axillary radiotherapy versus axillary lymph node dissection, the outcomes were not different in terms of control of the disease, but clearly the rates of lymphedema were less with axillary radiotherapy. So for these patients, if we find more extensive involvement of the sentinel nodes, we typically defer their axillary lymph node dissection until we get the final pathology report, discuss it with a multidisciplinary team, and if the decision is to go back and do an axillary dissection, we do, but often the decision is to actually give radiotherapy, which is as good as an axillary dissection with less morbidity. So that's another reason where we don't use much frozen section for these patients as well. But perhaps the most compelling indication for intraoperative frozen section for axillary nodes is for patients that have documented involvement with the disease, the presentation, and then get neoadjuvant chemotherapy, and now the lymph nodes clinically become negative, and then they go to surgery with a sentinel lymph node biopsy or a targeted axillary dissection. For those patients, it's important to find out if they have disease remaining in the lymph nodes, because those patients, per guidelines, they will require an axillary dissection, given that there is still involvement of non-sentinel nodes if the sentinel nodes are involved. So for those patients, I think it can be useful to do a frozen section and act upon the information, performing an axillary lymph node dissection. And of course, we're now conducting clinical trials to see whether we need the axillary dissection for this group of patients. And if those trials show that you don't need it, eventually I think the frozen section of the lymph nodes will probably go away, as it pretty much has gone away for patients in terms of the primary tumor in the breast. And of course, the last thing I want to say is that intraoperative frozen section of the sentinel nodes can also miss small metastases. The sentinel nodes, they become evident on permanent assessment. So it's not a foolproof method of being accurate 100% to detect disease, because if it's very small disease, it can be missed on frozen section. So again, a decreased use of a frozen section for patients with breast cancer.